Yeah, ladies and gentlemen, thank you for participating in this best practice EI treatment webinar from our side, from ESW Vision. My name is Daniel Rechberger and I'm a sales manager. Petra Bruckmüller, our president and CEO, sends her warmest welcome and sincere apologies that she couldn't join today. Normally, she also likes to join our webinar sessions. Unfortunately, she wasn't able to join today. But we have a special guest tonight, or in this evening, here in Europe at least, which is who is Erik ROBERTSTAD. He's an outstanding optometrist and working for Interoptik Norway. And he has already some years experience with EI, and I think he will have quite some interesting things to tell us about his experience that he has made with EI. Thank you, Erik.
You're welcome. Hello, everyone. I've heard that. Let's see. I'll share my screen first and see if we can get the technology to work. That's it. Yes, I've heard we have listeners from, or viewers from Canada and South America. We have viewers from Scandinavia and also from continental Europe, and maybe a few others as well. So welcome everyone, and I hope you will enjoy this presentation. It's actually a new one for me, focused on intense pulse light treatment of dry eye. I know that there were some marketing about dry eye treatment in general, and I will talk a little bit about also general treatment, but the main focus of this presentation is to talk about the treatment of evaporative dry eye. So those of you who were with me last week remember that I talked about the two different types of dry eye: aqueous deficient dry eye and evaporative dry eye. And also remember that there is not always a clear cut between them. It is, a lot of the time, it's a mix. Although, having said that, we believe that the majority of dry eye is caused by evaporative dry eye, or is the evaporative type. But it can be confusing sometimes, and you have to remember that the evaporative type also can have some aqueous deficient signs and symptoms. So remember that many people have a mix, and there is also very often several treatments options. So for aqueous deficient dry eye, we have environment, nutrition, and lifestyle advice on those three. Always keep that in mind. Tear supplements, plugs, scleral lenses. I'm just going to move this a little bit. And moisture chamber glasses. I know that in many countries, at least in the US, it's also quite common to make autologous tears. Also referred to as platelet-rich plasma, and that is a promising treatment for the severe dry eye patients we have. In Norway, that's really difficult to obtain. There are only 2 hospitals that are allowed to make it, and it's very complicated to get that done. Anti-inflammatory therapeutics and also mucus producing therapeutics are available and options. So for evaporative dry eye, again, environment, nutrition, lifestyle, think about lipid supplements, sort of oil emulsifications, home-based and office-based lid warming. That can be done with eye bags, with blephastine moisture chamber glasses, LipiFlow treatment, or the new iLux treatment, and perhaps also in combination with lid massage. Some people treat also glands by probing them. Again, we can have in the vicious circle of dry eye, it can also, again, turn into an inflammatory state, and inflammatory treatment can be used. And then we have IPL treatments, intense pulse light treatment. Or as EI treatment, they like to also add an R in there. So it's intense, it's IPRL because the R stands for regulated. And for both of these groups, irrespective of aqueous deficient or evaporative deficient, remember that improving lid health and hygiene often prevents formation of biofilm. And biofilm will affect the tear film stability. So it's really important to control the lid health and the hygiene of the health. Confounding factors or factors that can confuse us, neuropathic dry eye disease or neurotrophic conditions. In neuropathic disease, patients very often have a lot of symptoms and very few or no signs at all, but they have the classic symptoms of dry eye. Neurotrophic, we can often see signs of dryness, but the patient is not complaining. That's the short version of that. So let's move on to some cases and some treatment guiding. This is a patient of mine that I treated, started treatment in February this year. And it was a little bit difficult because as you can see, we had 5 weeks of lockdown in between here. So on the 12th of March, it was kind of difficult to take consultations. But we saw him back, and the picture on the right-hand side, you can see how much better he is. On the left-hand side, you see swollen lids, a lot of redness, little bit more redness in the conjunctiva, and you can see signs of blepharitis. So we've done a combination treatment on him, including intense pulse light. When treating dry eye disease, it's always good to keep track of your objective parameters. So I would suggest to have good parameters that you can monitor through the process and also quantify again after your treatment so that you know that you reach your targets. The severity is easily quantified with questionnaires like SPEED, DEC5, OSDI, and your objective measurements. There are many of them. They can include osmolarity, non-invasive breakup time, lipid layer thickness, or tear film stability measurements, MMP9 to see whether it's inflammatory or not. It's an inflammatory biomarker. So those are your objective measurements, and we do that with instruments for the purpose. So as you can see here, a photo of my mammography. Maybe that's not something to monitor through a treatment process, but it gives really valuable information prior to treatment. Also subjective findings. So I think discussing the various methods we have available, you all know that lid warming and massage will actually help patients. And if you do that, people will get better. The trouble with it, for me, is that most people don't do it. It's so hard. If you ask people to do complicated things, most of the people will not do it. And you end up with lots of these kind of things end up in a drawer. And I often, during several years, I asked, how did it go with your lid warming and your massage? And you get the reply, oh, was I supposed to do that for a prolonged period of time? I thought it was, you know, and some people will reply, I never actually did it. It was too much hassle. So that's the trouble, that most people will not use it. And the ones who do, who are compliant, who use it very regularly, will actually get benefit from it. Also, the same with moisture chamber glasses. They work excellent. They give a significant improvement if people use them regularly. So when we ask our patients, what do you prefer? We want to do something with your glands that are obstructed and poor quality. We show them photos of their glands taken by the slit lamp. usually squeeze them and show them what it looks like, and they understand that that doesn't mix very well with basically salty water. So people understand that their tears will evaporate quickly and burst. So I often use the comparison with making a perfect soap bubble mix. If you blow out a soap bubble, it will fly for a long time if you've made the good mix. If you have a poor mix, you will blow the soap bubble and it will burst immediately. And people can understand that and relate to that. And they know that, so if you ask them, would you like to do lid warming at home? I'll show you how to do it. You can do that every day for about 10 minutes. It will help you. Or would you rather like to come here 3 or 4 times, separated by 2 to 4 weeks? And most people would choose the last option. So that's how we basically started. But before we do intense pulse light treatment, I would like you to consider these 3 things. It's number 1, healthy lids. Are the lids healthy? Do you see sign of blepharitis? Do you see sign of biofilm formation, crusts, redness, stuff like that? Treat it. Make sure you control the lid environment. Number 2, you need to consider what is the grading of the expression and what does the quality look like. Because the more severe the condition is, the harder it is to get a really good result. And I will talk about that later. So in other words, it's always good to start, it's easier to start treating people before it gets really bad. Number 3, meibomography. I think it's not crucial. It's not something you must have, but it's really nice to have it. And that is because, again, it's so easy to swap the screen around, show it to the patient and see what does it look like. And you need to set realistic expectations. If you have glands like on the left picture, we know that, okay, they are fully there. If it's like on the right-hand side, you can see in the center, 3 or 4 glands fairly visible, to the right, some small nuggets. And you know you have atrophy. We know that we have a lot of the glands have atrophied. And of course, it's harder to get a really good result with any lid treatment, with any dry eye treatment that where the purpose is to improve the quality of the glands secretion. Then it's hard if the glands are not there. So if you see, you know, I could have showed you another photo of no glands at all, and then there's obviously no point of either sending home with eye bags or doing an IPL treatment if there are no glands. So you need to look at it, and you can do this in white light as well, and you can look at it, but it's harder to at least it's harder to communicate with the patient, and it's also somewhat harder to make comparisons over time. So it's better with infrared light. Also, as I said, prior to IPL, make sure that you have a healthy environment. Make sure you control the lid margins. Healthy lids and clean margins almost is a requirement for good results. We want to improve the stability of the tear film, and hence we must prevent the building of biofilm. So also you need to evaluate if you should do an in-practice lid hygiene, microexfoliation, perhaps with a rotating Blefex or something like that, or forceps and a golf spud and lid towelettes to clean it up. If you do a proper cleaning, you can often send patients home, and they can do the aftercare. They can continue the cleaning at home. So also make sure then that you teach the patient how to do it. You need to show the patients how to clean their lid margins, because some people just do it wrongly and they're not hitting their wet margin. They're only doing maybe on the outside. And so you must teach them how to angle the lid outwards when they clean, and also how to stretch the eyebrows so that the eyelashes are pointing upwards when they do the upper lid. That's very important. Be aware of harmful makeup removers. Ask people, what do they do to remove their makeup? Because there are many products out there that are not healthy for the eyelids. They're too strong, maybe containing a lot of alcohol, parabens, and stuff like that. Those are ingredients that we suspect over time will actually kill meibomian glands. So you don't want to lose more meibomian glands that maybe the patients already have lost. So make sure you give them a good product, a kind product without alcohol or without preservatives and parabens. Here's an example. This is a patient with probably a combination blepharitis. At least we know for sure with the collarettes here that this patient has Demodex blepharitis. And the bottom photo, I've angled the lids, the upper lid, angled it so that I've taken the photo towards the lid margin. And you can see there's a lot of crusting. So we clean this with Blefex. And after a few minutes, it looks like this. And for sure here you can see on the little thin lash there, you can see a cluster of Demodex tails. So those are the tails. It looks like a little lump, goes around the lash. There's another one further away, but it's a little bit blurred on the photo. If you want to see the individual tails, you can rotate that lash. So you take a forceps and rotate it, swirl it around like this when you're bored at work, and you will see the tails move. So they're live and kicking. But we often get, when we teach this to optometrists, we often see that or hear that they can't really see the Demodex. And it's just probably because they are stuck together and it looks like a small lump. So I often combine intense pulse light with manual gland expression. And I do that approximately like this. So if I have a low degree of obstruction and the quality of the meibum is fluid, I will be happy to do intense pulse light alone. And that's it. All you need to do the intense pulse light, follow through 3 or 4 sessions, and you can create great results. If you have a more severe grade of meibomian gland dysfunction, I would do expression after the intense pulse light. So I'll do the intense pulse light first, and then afterwards I will gently squeeze all the glands systematically using maybe a paddle. I'll show you that afterwards. If I have more than 4, this is a quantified grade. This is a combination scale of quality and expression. So if I have more than 4 in total, I would usually combine treatments and do meibomian gland expression and IPL together. And most of the time I would do 10 to 15 minutes lid warming in advance. And this is because if the glands are really obstructed, I would like the meibum to melt. And I want to know for sure that I can squeeze it out. So I've done my mammography and I know that the glands have not atrophied, but it's really blocked and really like toothpastey looking. I would like to melt it, squeeze it out, make sure that the glands are open, and then do IPL. It probably doesn't matter if you do the heating first and the expression, then the IPL, or vice versa. I don't think it really matters. What matters is that if you need to know that when the patient leaves your practice, that the effect you create with the IPL treatment actually can take effect by the glands being able to let go to produce more healthy meibum. So plan your treatments. I would look at the face shape and the size. I would take a careful look at the skin. like you can see here. This patient has rosacea. You can see on the nose as well, rosacea. Also, you need to look at the size, as I said, to know if you can fit in the 5 flashes as planned. Sometimes you need to angle them differently on small faces as opposed to big faces. Sometimes I do include the nose in rosacea patients. Some people ask me that. And that is because the IPL also has a cosmetic effect. And the cosmetic effect will often be beneficial to rosacea patients. And I don't want them to end up with a red nose. So I would sometimes include the nose, depending on how it looks. So just look at the patient and plan what you're going to do. I'll show you lid warming and how I do that. I use, most of the time, I have a microwave oven just right next door to me. I measure the temperature, but you still get some variation. So I would put a cloth onto the patient's face like this. And that will take down the temperature a little bit to begin with. So if my eye bag is a little bit warm, I put the cloth on, put the eye bag on, leave it on for a few minutes, then drag the cloth off. So by that method, you can kind of, it's like walking into a really hot water. You know, when you put your toes in, it's really, this is impossible, it's too warm. But you know that, well, okay, if you put your foot in and let it stay there for a minute, you can gradually go into the heat. And in the worst cases, I will actually use 2 eye bags. I would put one on for 7 minutes. I'll go and get another one and I'll swap them. And this is because otherwise the temperature will fall. And by using 2 consecutive eye bags, I keep the temperature at a high level. So that was lid warming. Now I'm going to show you a short treatment session using EI. And here we've covered the eyes with the metal shield. This is a metal goggle, so light can't go through it. People will still experience light even though you have the metal shield there because it's a strong flash. I put the transparent gel on the patient's face. And once I've done that, I like to evenly smoothen it out with a wooden stick. I don't want the gel to be too thick or too thin. So I want a smooth layer. And I'm doing the flashes. So here you can see that's number 3. And this young lady, her face is not that wide. It's a fairly narrow face. So that's why I'm doing the 5th flash horizontal. It's not part of the official CE protocol, but it's how I would do it in many cases. Then I will wipe off the excess first with the wooden stick, throw that, and with some facial tissue afterwards, then remove the goggles. By the way, this is the same patient in September 2018. And it's amazing. Her eyes are so much better. So she came in now recently for refreshing, what do you call it? We schedule patients for a new treatment, a repeated treatment, 9 to 12 months after their original treatments. She came in for that. And this is how her glands look like in September 2018. And they have become so much better. This is how you could position the flashes. On the left-hand side, it's the normal method. And on the right-hand side, that's what I just showed you in the video. Now we will see the same patient using manual expression. So you can see now what it looks like when I squeeze her glands. I'm using a simple paddle. So that's I'll just show you that. It's a paddle like this one. It has two similar sides. It's easy to use both on the upper lid and the lower lid. and I'll show you the video. So we're squeezing her lower lid here, lower left lid, and in the microscope, you can see that what comes out now, it's completely different from what it was in 2018. So it's beautiful to see how much better it can be 1.5 years after. Here's another patient. This is just to show you that sometimes you need to be patient. You need to take your time when you do the squeezing of the lids. So upper lid, use the paddle, go underneath the upper lid and squeeze. And you can see here that the meibum is fairly thick and creamy, almost pasty, and continue for quite a long time on the same location, and it continues to empty for quite a long time. So it's important to remember to take your time in each position when it's necessary to do that. After the treatment, I would wipe off the excess with a lid towelette. So I would pull the lower lid down, wipe off, upper lid up, wipe off, just to avoid getting too much grease in the tear film. And this is just show you, what I use. The wooden sticks, they are disposable. I buy them in packs of 100. These are my metal shields, my paddle, my vermin expressor, the lid cleaning towelettes, and the eye bag. And also, when you've seen patient, when you do this treatment, it's important to, prior to the treatment, we clean the area that is to be flashed. So take away makeup. Some people use day creams with UV protection. You want to take away that. Some people use a lot of makeup. You want to clean that off so that the pulsed light get the full effect. And we use lid towelettes to do that as well. So after the treatment, people would very often like to, if they're going back to work, for example, they would like to put their makeup back on. So we make sure we have facilities where people can go, they have a makeup mirror, put their makeup back on after the treatment, so that they can do that in peace and quiet. I think in between the sessions, inform about what to expect. I tell my patients that about 50% of the patients can experience symptomatic relief immediately after the first treatment. So that is, to say almost same evening or the day after. Usually it will be a little bit of a honeymoon effect. It will only last for a few days. And then that symptomatic relief will start to drop, will start to tailor off. They come back for their second treatment, usually after 2 weeks. And I think it's important not to wait much longer than 2 weeks. So I try to be accurate on how I book the appointments. They come back after 2 weeks for the second treatment. I would ask them, did you feel any relief or not? About 50%, it's my kind of gut feeling, will experience improvement after the first treatment, and about 50% will not. So, but it will build up. So you do the second and the third and maybe the fourth treatment, and it will gradually be better. Sometimes you do not actually get an improvement even after the third treatment. But I've seen many times when I call people back for the follow-up exam 4 weeks after the third treatment, then people say, well, it is noticeably better, significantly improved. And sometimes it doesn't work. I would reckon that is around 15% of the patients. Between the IPL sessions, you need to make sure that you maintain that lid health that I stressed earlier. Show people photos, make people understand that the glans openings are on the lid margin and they need to keep them clean. It's really good if you teach that and show them photos of their own eyes. Consider lipid emulsion drops or other lubricating drops, always preservative free. And by the way, it's been induced too, or induced rather, since 2007 was the first time it was stated induced that really you shouldn't use drops with preservatives. And again in 2017, obviously. I really can't see why you would need a preservative in a drop if you can avoid it. Consider lifestyle and give advice on that. Give advice on taking breaks from computer work, studying, you know, take short breaks, make people understand also the value of taking a walk outside. If they can in the evening, take a good walk. If you can do little pieces of lifestyle advice like that, it can be of great benefit. Always agree on an evaluation appointment. You need to see people back. If you don't do this, you will lose the opportunity to really gain experience. You have to know whether your treatment actually worked or didn't work. And the only or the best way of doing that is to get people back to you. So I would schedule them back in 4 to 6 weeks after the last treatments. The added benefit of that is that if you feel that you need a 4th treatment or a 5th treatment, then you can always change it and do that treatment and then reschedule another evaluation appointment. So when I get people back, I would use the tear check to measure again non-invasive breakup time, stability measurements, tear volume, those numbers that you would like to see improved. I use speed, so I would repeat speed and quantify their score on that. And if the MMP9 was positive prior to treatment, I would repeat it to see if I can get people out of the inflammatory state or whether it's necessary to start an anti-inflammatory treatment. And then in the end of that session, I would grade the MGD again on expressibility and on quality. Talk to the patient, reinforce your advice and motivate them on lifestyle aspects. And then I would reschedule a maintenance visit, maybe in 12 months. And it's amazing how long time this treatment actually lasts for. But occasionally we get people back at 9 months. So I would normally schedule them on 12 months and I will tell them if you feel symptoms before your 12-month appointment, then just please call our practice and you can come earlier. And some people do that, not many. And last but not least, just stressing this, you need to see again, you need to see them again, you need to do the follow-up. Otherwise you will lose invaluable learning. So for me, IPL is a tremendous practice builder. Dry eye patients with increased quality of life is what you get out of it. They will spread the word. Contact lens wearers with significantly increased comfortable wearing time, or some cases actually where people can't wear contact lenses at all, but after your treatment they can. Maybe not for a full day, but at least for a few hours for their tennis lessons or whatever they do activity. So you get all kinds. But I think the contact lens patient base is a great opportunity to tap into and also to do preventative medicine by discovering with my mammography those patients who actually have lost or have atrophied glands and do something about it before it's too late. So that's it actually. You don't need to be an expert to start, but you need to start to become an expert. It's my guidance in life. I wish you all the best and good luck, and open for questions.
Thank you, Erik, for this interesting presentation. to our participants, you can use the Q&A function to ask questions to Erik. While we are waiting for the questions to come in, I would also like to show you an example that we have just received from one of our EI users in Turkey. So on the pictures, you can actually see a patient with MGD and Demodex, and the doctor treated the patient with 3 EI sessions and hot compresses and also omega-3. And these are the results that she achieved. I don't have anything else right now. I'm not sure. If there are no further questions, I would also like to remind you about our next week's webinar. Again, in the afternoon at 4 p.m. with Erik ROBERTSTAD, and in the morning at 8 a.m. Central European time with Dr. Luca Vigo. It's going to be about the future of dry eye management. And I think I saw just another question pop in, if I'm not mistaken.
How long do I express for? There's a question there. How long do I express for? And that really depends. You need to look when you express and see if it continues to come. But when you express for grading, you're supposed to hold the pressure there for at least 10 seconds. When you express for manual expression, it depends from case to case. As I showed you earlier, sometimes you really need to hold for quite a long time, maybe 15, 20 seconds on each location.
Okay, I think you have answered these. What are your thoughts on systemic conditions involving dry eyes?
That's a good question, because there are studies that have showed that in Sjögren's patients, you do get atrophy in the meibomian glands, and you also get meibomian gland dysfunction to a larger degree than normal population. So although Sjögren's originally thought to affect the lacrimal gland, and slowly the lacrimal gland will atrophy, there are studies showing that it also affects the meibomian glands, and therefore on Sjögren's patients, you can get a good benefit from IPL treatment to protect the meibomian glands, to make them work as good as they can. And you can combine that treatment with traditional treatment for aqueous deficient dry eye disease, like Sjögren's is usually about, like plugs. I use plugs and artificial tears. Yeah.
Thank you very much. If there are no further questions, I would thank you for joining the session today and for sharing your experience and for sharing how you and your practice are working. Yeah, thank you once again for joining, and I hope to see you soon, latest next week in our webinar about the future of dry eye management.
Okay, see you next week. Thank you. Thank you for listening.
To our participants for joining this session. I hope to welcome you back next week as well. Bye-bye.